Hopefully lunchtime was a tranquil interlude for you, and hopefully the rest of the afternoon can go that way also. I did check into the timing of our third exam. Third exam is scheduled for Friday, November 6th at 3 p.m. And that's a 3:00, I guess, p.m., not the 3:10 sort of thing. 3:00, it looks like, in the Urey Lecture Hall. 50 multiple choice questions, half from Katie, half from myself. And by the time we get to that, we'll be really about done with the semester. While we're sort of waiting around here a little bit, I'll inquire as to whether anybody has any questions. I think we've got ample time to finish up the antipsychotics today. And so when we finish that up later this afternoon, just in a few minutes here, really, I'll give you the signal that that's the cutoff for the third exam. And then tomorrow, in which we'll, starting with the opioids, will be the first topic on exam 4, which comes up on the 20th of November.
Keith, I was wondering, is it a comprehensive final?
No, it's not. It's not purposely so anyway. I mean, some names and so on that have been rooting around since the beginning of the class might arise, but there will not be, purposeful questions that are aimed at going back and bringing the whole thing together. It'll just be topics starting with opioids and then through the rest of the semester, which will be directly addressed on that exam. Good question. We used to do a comprehensive final in here some years ago. It's been a while now since we've done it, but we just eventually got to the point where, for our particular purposes anyway, in this class, we thought it was maybe the most effective approach to go with an exam which is just kind of a regular exam. Glad you asked that, though. It's a good question.
And then another question real quick, I'm sorry.
No, that's fine. Go right ahead.
So I know in in MedChem we were learning about neuroleptics, and I can't remember exactly. Are these the older antipsychotics, like the ones that target the dopamine receptors?
Well, that's probably not a bad way to think about it. And pretty soon here in this topic, we'll be taking a look a little bit at some of this generational stuff as far as the antipsychotics are concerned. So, I think it's a little bit loose in terms of how that neuroleptic term is used, whether it applies to the whole category of antipsychotics or not, or whether it's more related to the so-called first generation antipsychotics. And I think that's actually a pretty good way to look at it in using that neuroleptic title for the older agents. Although for my purposes, I put the neuroleptic label in there just for continuity, so that if people were running across it like you obviously have, they would fit that in here. But on the exam, I won't use that neuroleptic terminology. Another very pertinent question. Thank you. Okay, well, let's march forward. Moxie is another name we have for Olivia, the black cat, and she woke up long enough to have a little lunch herself and then is back in slumberland now. The dog got to lick out the cat food cans, and so she's also a very happy character right now. So one of the topics that is very interesting, but we only cover sort of secondarily in this course is the whole topic of hallucination and mimicking of hallucination by so-called psychotomimetic substances. Sometimes the terminology psychedelic is also utilized. There's a lot of different names that come up with that. So we sort of incidentally talk about hallucination and so on, but we don't have a frank segment on it. But they are amongst the most interesting drugs out there. And although they're some of the more straightforward aspects of hallucination and so on are fairly well understood, the whole category from either a neurological or a pharmacological standpoint of hallucination is underdeveloped because of sort of the brakes were put on that research back following the 1960s, early 70s. And for a few decades, it was just taboo, basically, to even put forward proposals that related to hallucination. So although there's a lot to be learned there, some of that learning is yet to come forward. But I think it well in your lifetimes, because the last 5 to 10 years have seen a burst of interest in these topics again, and the funding agencies are beginning to respond to that a little bit, which of course is required to do research. So anyway, there's quite a fascinating overall topic of hallucinogenic drugs. Most drugs are or I'll say many, not most, many drugs are hallucinogenic, but the dose has to be pushed pretty far. The ones that have the drugs that have garnered the most interest to date are those which produce hallucination at lower to moderate sorts of dosages. Although peyote, as an example, is one that doesn't produce hallucination as that remarkably low amounts as something like LSD does. There's reserpine again. Our friend, the Diagnostic and Statistical Manual. Positive and negative symptomology associated with schizophrenia. So I've tried to list out some of the more prominent negative and positive symptoms. And to get exactly what is meant by many of these categories, we'd have to pull the DSM out and look at it in a more definitional sense. But to sort of conclude what we mean by the bullet points that are listed in this particular slide, speech-related problems, memory, working memory-related problems, weak emotional expression or affect, sometimes it's called, and sort of some challenges associated with sociability. Positive symptomology of note include delusions and hallucinations. Emotional expression makes it on there again, and I'm not sure exactly how to differentiate between this and what we saw on the previous slide, but anyway, emotional expression related sorts of things, thought cognitive related disorders, and behaviors which typically are labeled as unusual, at least in terms of sort of typical societal context for behavioral sorts of things. So antipsychotic drugs are differentially capable of impacting negative and positive symptomology. They have a better chance of sort of blocking what's not supposed to be there, like hallucination, than bringing something back that's minimized under the negative category. So when we think of those substances, whether we're referring it to schizophrenia or not, which are capable of blocking or reducing hallucinations, we are typically talking about antipsychotic drugs in that particular particular regard. Whoop. So the next slide is titled Mechanisms of Action. And I probably would be better addressing this slide as apparent mechanisms of action, because many of the characteristics that we're going to talk about in the next few minutes may or may not be related to the underlying changes that are occurring in the system, which are dealt with by trying to use antipsychotic drugs. So this is a bit of an elusive category, much as a lot of drug mechanisms are, particularly nervous system related mechanisms, where we see a characteristic, one or more, and we notice that there's a substantial correlation between the presence of the drug and the presence or absence of that particular characteristic. And therefore, we classify or label that particular thing that we're looking at as something related to the mechanism of action for the drug substance, which it may well be, but sometimes I think we're probably so far missing the really discrete mechanisms of action which accompany the activity of complicated central nervous system agents like the antipsychotics. So, but looking at this in kind of a traditional sense, the dopamine hypothesis postulates that unusually high dopaminergic activity results in many of the problems associated with schizophrenia. And one of the real focal points of this particular research outlook is on D2 receptors, which we're somewhat familiar with already because of a nice introduction that Katie made about receptor subtypes in the dopaminergic area. There certainly are impacts that antipsychotics have on other dopamine receptors, but the center of this so-called dopaminergic theory of schizophrenia does focus on D2 receptors, and there's a pretty substantial correlation indeed between perceived antipsychotic activity and the ability of antipsychotic drugs to block dopamine 2 type receptors. I don't know how many people were on at the time, but we were talking about this just a little bit before class. And the so-called first generation antipsychotic drugs, and we'll talk about what this means here in a few minutes, are particularly likely to be substantial D2 antagonists. Now, make sure and differentiate between, when we're talking first generational things, we could even be talking about reserpine in that regard, because reserpine really was the first dedicated antipsychotic drug utilized in Western medicine anyway. But as we've already seen a number of times, reserpine doesn't seem to exert its activity by blocking dopamine or other monoamine receptors per se, but rather by depleting the amounts of these receptors in storage vesicles presynaptically. So whether you're blocking a receptor, whether you're depleting the neurotransmitter, the overt effect that you see is sort of a downregulation of that particular system, even though the mechanism of action is a little bit different. So by talking about first generational antipsychotics here, I'm excluding reserpine from that particular conclusion. D2 related effects do have other aspects to them beyond um, psychosis. And an example given here is that um, nausea and vomiting and sort of tranquility of the GI tract is at least partially under the regulation of dopamine, and therefore, for quite some time, one of the categories of anti-nausea agents have been the antipsychotic D2 antagonists, and they're still used in that regard, although there are many other choices now available for dealing with severe nausea and vomiting and so on. And as we will see soon, you probably already know that there are substantial side effects to deal with regarding the antipsychotic drugs. So if something else like a serotonin type 3 antagonist can be utilized for the anti-nausea purposes, it's probably a better circumstance relative to the risk-benefit characteristics of antipsychotics. So this is one of the places where we can really bring serotonin into the realm. I've stated a number of times that I don't think I could give you an example of an antipsychotic drug that is not a D2 dopamine antagonist. Probably can't make quite that strong an appeal with respect to serotonin, but just about. Even though dopamine may be the sort of ringleader in terms of looking at mechanism of action in this regard, serotonin is close behind. And I'll differentiate a little bit between first generation and later generation drugs in that regard upcoming. But I think it's fair to say that most known antipsychotic drugs at this point in time are both D2 and serotonin antagonists, particularly the type of serotonin receptor known as the 5-HT2A receptor. Now, this slide is a bit antiquated in that I say the numbers are taken from Goodman and Gilman. Well, I eliminated that slide. So you're not going to be able to see that directly, but I think it's still in there in which you take a look at the correlation between a drug binding to D2 receptors and apparent psychotic action. And there's a very tight correlation in that particular regard, which is one of the reasons why molecular-based pharmacologists tend to emphasize the dopamine ideas about antipsychotic action so dramatically. Now, the newer generation antipsychotics, and again, I'll list a few of these out in a few slides here, on average, tend to be more likely to be active in the 5-HT system than the first generation agents. But again, pretty much all generations are involved with both serotonin and dopamine. Sort of an interesting singular example of this is chlorpromazine, which is a drug that you should recognize. It's old now, but it's the prototype first generation phenothiazine antipsychotic. But it's sort of a bit anomalous in the dopamine serotonin realm in that chlorpromazine, although we tend to classify it as a first generational agent, is quite capable as far as blocking serotonin is concerned. So it's a really good example of a drug which seems to participate in these activities by interactions with both dopamine and serotonin. So on this slide, I just threw a few names out there just to orient you around some agents that you might be familiar with. It's a mix of agents, phenothiazines, butyrophenones, and later generational agents on this particular slide. I didn't put chlorpromazine on there because we'd already talked about that in the previous slide. But the first two agents listed here are phenothiazines. Haloperidol is an example of a very prominent butyrophenone. And then the latter three agents that are listed are so-called second or third generation antipsychotic drugs. So I don't know how successful it was in putting these out there as something that you might be familiar with. I would suspect that ziprasidone and risperidone, being newer generational agents, are likely to be ones that you've heard of. Haloperidol, because it hangs in there as an older agent that is still so commonly used, and clozapine, because it's usually considered to be the prototypical new generation agent, even though that new, I should put quotes around that, because I think clozapine has been out there for about 3 decades now. So that puts it as a lot newer than chlorpromazine, but older compared to an agent like ziprasidone. So we begin to differentiate a little bit these generations of antipsychotic drugs. And I've called these first generational agents traditional antipsychotics. I don't know if anybody else uses that terminology or not, but if you picked up Goodman and Gilman or Katzing from a ways back, you would see agents like these and their relatives listed. And so that's why I've called them traditional. Again, I consider chlorpromazine, or one of its prominent trade names is thorazine, which you might be more familiar with than chlorpromazine, as the prototype in this area. Although in some ways, it's not prototypical, because I've listed it as an anomaly because of its great ability to interact with serotonin on this slide. But nevertheless, mostly because of temporal aspects and traditional use, chlorpromazine is frequently listed as the prototype in the older type agents, again, excluding reserpine. Mellaril is another very prominent agent from the earlier era, and haloperidol, which is the prototypical butyrophenone agent, has very similar pharmacology to the phenothiazines, although in terms of absolute ability to block dopamine receptors, some psychiatrists especially consider haloperidol to sort of be the lead agent in that particular regard. And that's why you still see it used a lot today, even though it's a pretty old drug. Let me pause here for just a second to say that if we went back if we pulled Goodman and Gilman out from the early 1950s, we would not see these drugs at that point. The transition occurred between the mid 1950s and the early 1960s, from an era in which we had literally nothing from a pharmacological standpoint to some agents which at least showed some promise in terms of helping out as far as psychosis is concerned. So this tradition only runs back to about the mid 1950s, which interestingly is also about the time that we figured out that reserpine had antipsychotic as well as antihypertensive activity. So from a purely temporal standpoint, the first agent to appear in the 50s was reserpine itself in about 54 or 55. Now that's in terms of Western medicine in the United States particularly. Reserpine, of course, being a natural product native to the continent of India, had been known for its ability to produce dramatic pharmacological effects for hundreds and even thousands of years. So it's a very old agent in that regard. But it took a long time for us to figure that out over here in the West. And one of the reasons why we were lethargic in figuring that out is that we absolutely insisted upon studies having to be done in the United States before we would rate an agent as efficacious or not, even though cultural and scientific studies had been done in India and elsewhere in the world prior to that time. So, it took us a while to get the studies done here in the United States. And lo and behold, what did we conclude? That reserpine has um, activity, just as the previous studies in India had suggested. Um, but the phenothiazines were on the horizon anyway at the time that reserpine was introduced. And so as chlorpromazine came out in about 55 or 56, I think, somewhere in there, reserpine was pretty rapidly displaced, at least in the United States, from use as an antipsychotic drug. Not to say that it has no use or isn't ever used today, but the phenothiazines, as broadly based as they are in their actions, are still a little bit more specific than reserpine, and so it didn't take too long to make that shift away from reserpine. The apparent mechanism of action, as we have been talking about, is dopamine receptor blockade, particularly D2. And to this very day, if an individual practitioner is looking for a dopamine receptor blocker, they'll almost inevitably utilize one of the antipsychotic drugs, even though the dopamine blockade that they're looking at may or may not have anything to do with psychosis. These drugs are slow. They're a lot like the antidepressant drugs that we'll be talking about later in the course, in that although you get receptor blockade rapidly, and there certainly are biochemical effects which appear within hours of administration of the drug, the actual antipsychotic actions tend to be longer than that. They tend to be for many hours, in some cases, much longer durations than that. So they're pretty slow, which means, I think, that if dopamine is central to the mechanism of action, either there are downstream effects that are occurring in the dopaminergic system which take a while to develop, or there are other factors which we haven't really identified up to this point, which are responsible for the mechanism of action, but which take quite a long time period to play out. So I think if you could recognize these three drugs, recognize especially the dopaminergic blocking activity from an efficacy standpoint, and the fact that these agents are lethargic, that is going to answer some questions for you on exam 3. So let me switch gears here a little bit into some of the newer antipsychotic drugs. And again, new is a relative term, because some of these have actually been around quite a while now, but not as long as the first generation phenothiazines, to be sure. Clozaril is a dramatically effective antipsychotic drug, at least in terms of current context. Maybe a decade or two from now, that from an efficacy standpoint, it won't stand out, but right now it does. It's very, very efficacious. In fact, I'll make the statement, and others may not agree with this, but I'll make the statement that of all the antipsychotic drugs we have, clozapine is the single most effective. However, it's also got a lot of adversity associated with it, and many practitioners are reluctant to use Clozaril because of the different risk-benefit analysis associated with it compared to other antipsychotic drugs, first or later generation. Some of the newer generation agents, like Zyprexa and Risperidol, which are listed on this slide, have a better risk-benefit analysis than clozapine has, which results in their more likely utilization. But if we look at this, just purely from an efficacy standpoint, in terms of the way we envision antipsychotic drugs right now, clozaril is hard to beat in that particular regard. And these newer generation agents are more likely to be involved in the serotonergic system, as we've already talked about, but they're still substantial dopamine receptor antagonists. Now, many practitioners may, from a applied standpoint, find the first generational agents to be better dopamine blockers than the newer generational agents are. Nevertheless, from a research-based standpoint, if you look at the evidence, you find dopaminergic and serotonergic involvement with all of these drugs, older or newer. Now, some other receptor systems are likely to be involved also, and I'll mention in that particular regard sort of alpha adrenergic receptors, because if you look at the entirety of the span of known receptors which are involved with these agents, you see more than dopamine and serotonin. You see these other receptors involved too. And even though we tend to guide our thinking based upon how well these agents interact with dopamine, especially, and serotonin secondarily, some of the other receptor effects, or even non-receptor based effects with various other sorts of enzymes and so on, may well be part of the activity of these various drugs. And of course, although we tend to group these substances into categories like first generation and newer generation and so on, the individual agents do have differences with respect to each other, and some of those differences may well be related to targets beyond the realm of dopamine and serotonin. One thing that's pretty similar about the newer generation agents compared to the older drugs, though, is that they're slow. And so, whatever changes that are occurring within the regulatory schema for the neurotransmitters or other targets are taking a while to unfold with respect to these agents, as well as the older drugs. So I really must admit that I sort of mislabeled this slide. What it says is true, but it doesn't go far enough. And really, the things that we're talking about on this so-called newer drugs slide is those characteristics are really referable to one degree or another to the first generation agents as well as the newer agents. And one thing that is not listed on here, but I should have, because it's really the most prominent things. Let me just backtrack into the traditional category for one. It's probably no surprise to anybody in the room that in having gone through the Parkinson's material that Katie offered and that I summarized a little bit, that with such prominent dopaminergic involvement, these agents create effects with respect to motor control. And some of that is sort of, let me see if I've got it down here. I didn't really put it down here, but if you take a look at some of the so-called more general symptomology, you do tend to see some sort of corrections that occur relative to psychosis, which are positive. But the effects that we're talking about, although I didn't list it, and I should have here, are adverse effects associated with all generation antipsychotics. Although the motor problems are more prominent in the earlier agents than the later agents, which is one of the reasons many practitioners prefer to use the newer agents if they can. So these drugs don't actually cause Parkinson's disease, but they produce symptomology with respect to uh, secondary motor control tics and so on, uh, which are reminiscent of Parkinson's or related motor disorders. So, this is a very problematic sort of thing because antipsychotic agents often have to be used for extended periods of time, sometimes the lifetime of an individual, many, many years in many cases, if not at least very, very many months. So the probability that you're going to produce an adverse motor effect if the drug is used for such long periods of time is pretty high. And therefore, one of the moves into the newer generational agents was to find agents which were less adverse as far as motor regulation is concerned. And the newer generation agents are less adverse as far as motor symptomology is concerned, but they're not necessarily free of it. And so I don't want to give the impression that because we've switched over to newer generational agents in many cases, that the adverse motor effects are completely gone. They're in many cases they're not. Now, first and later generation agents all are to some degree regulators of lactation, because lactation is under dopaminergic control, especially. And so sometimes unwanted lactation occurs with these agents. The metabolic terminology listed here is extremely important. And it's important to note that although we may hear more about it with respect to later generation agents, all antipsychotic drugs, in my estimation, are metabolic disruptors. And the most obvious place for that, and especially in the newer generational agents, is unwanted weight gain. And we're not talking in many cases about trivial amounts here. We're talking about substantial amounts. So one of the things that has not been solved in the realm of antipsychotics so far is trying to produce agents which don't disrupt metabolism. Again, these agents don't, produce diabetes, but they mimic or exacerbate some of the problems which we identify with diabetes. And we can talk more about that in the spring when we're talking about pancreatic hormones. Yes.
I had a question real quick. So you have lactation up there, and but that made me think. So would this cross the placenta, since it's so lipophilic that can cross the blood-brain barrier? So would they have to go off of these medications if they're pregnant?
I don't know whether, I have to admit ignorance. I'll have to look that up about whether individuals go off the medications or not. But I think that concern about teratogenic and other fetus-related effects are of great concern with respect to these agents. So I think sometimes it's a rock and a hard place there
Gotcha.
in terms of how you go about that. It's a very good point. I'll try to refresh my memory on that for next time. But I think there are serious considerations as far as fetal adversity is concerned. The other thing that I indicated on this slide is that just because an individual is utilizing an antipsychotic drug, and I use neuroleptic there, antipsychotic drug, does not necessarily mean that they are schizophrenic. The widespread receptor activity of these agents results in their utilization in many other ways also. So I tried to keynote the general pharmacology and toxicology of these agents, really not sort of distinguishing much between generations at this point, but just looking at things that the drugs do that we want them to do and that we don't want them to do. And of course, that includes anti-hallucinogenic effects, the reduction of affect or emotionality. Here's the little one on motor activity that I was searching for in my mind earlier. Enhancement of cognition and betterment of the social setting. those are pretty much characteristics of all known antipsychotic drugs at this time, although more or less depending upon the particular agent, of course. Antipsychotic drugs are depressants, but they're different types of depressants than the sedative hypnotics, because as far as we know, GABA doesn't play a really huge role in antipsychotic activity, whereas most of the earlier CNS depressants that Katie and I have been talking about are referable to the GABA system. Here's where we talk a little bit about dopamine blockers produce movement-related problems. We already talked about that. Gravitationally based hypotension occurs with some of these agents, and that's a difficult thing to deal with. Orthostatic hypotension is not easily treated. Metabolic disorders, as we talked about a few minutes ago, and then blood-related disorders, which can be very severe in the worst cases, especially with respect to clozapine. Now, sometimes other agents, which aren't technically antipsychotics, are utilized to help the agents be most effective. And an anticonvulsant like Topamax is an example of that. Other anti-epileptic type drugs may also be utilized in this particular regard. And the sort of simplistic approach that I take to thinking about these agents is often not realistic in terms of the clinical setting, where it's not just one agent that's being utilized, but more than one agent. So, for example, sometimes we'll see a newer and an older generation agent used together, and often that is because the practitioner, psychiatrist is looking for maximal dopaminergic blockade, and they're getting more of that if they add a older generation agent to a newer generation agent. And then sometimes, of course, neurological and psychiatric disorders are not necessarily fitting the nice tight little categories that we talk about in class. And there's characteristics that span the classifications, and in those particular areas, you're going to see a combination of agents and antipsychotic plus something else or some other agents, and plural is not uncommon at all. So to see 2 or 3 or more of these agents utilized at the same time sort of, boggles an academic pharmacologist like myself, but in terms of the reality of the clinical setting, sometimes that's the case. So just to wrap things up, I know we're just about out of time here. We're going to be able to cut this off, I think, pretty readily. The search for better antipsychotic agents is definitely underway and has been underway for many decades. And the newer generational agents are basically reflective of that, although those problems that we've already noted, especially with respect to motor control, lactation, metabolism, as well as some other things, we would love to see antipsychotic agents which were as efficacious or more efficacious than the current agents, but which are lower in their ability to produce some of those adversities. That can be said about any particular drug category, but I think that the utility of antipsychotic agents is delayed to some degree at this point because of the adversity that's associated with these agents. So to produce agents which are more efficacious and less adverse in this particular area is likely to be something which will greatly advance pharmacy and medical practice during your lifetimes. We may have to look beyond dopamine and serotonin. Glutamate is certainly a possibility there, but we may even need to go beyond sort of totally different paradigms about what's going on with respect to antipsychotic drug substances. And so you're likely to see, and I hope you do see, some very different type agents during your lifetime. And the newer generational agents, there's been a lot of Me Too that's going on there, although in my estimation, at least, not a lot of differentiation between those agents in the Me Too realm. So maybe we have to go beyond Me Too and to something that's really different. to find agents which are of better liking to us in the efficacy, toxicity, interaction sort of thing that we were all always talking about. So keep watching. It's likely to be an evolving area. And so we've gone from not having any antipsychotics available to numerous available agents now in the last 60 years, with more changes to come. And thank heavens, at least we've started the revolution. Now we've got to complete it. Okay, I think we're out of time. Everybody, that's the cutoff right there. When I start up on the opioid agents tomorrow, that will be material not on the upcoming third exam. Okay, I'll answer any questions if there's anybody around, and beyond that, I'll see you tomorrow at 1 o'clock.
Keith, I had a student who sent me a message about, they said they, in the pharmacy during practice, they actually see another drug, quietapine.
Exactly. That's very commonly encountered newer generational agent.
Okay, and its mechanism of action is similar to some of the other newer generations that you've been talking about as well, correct?
Yes.
Okay. And then another question that kind of popped up, and hopefully this person's fine with me asking about it, is clozapine on the REMS program because of the blood disorder potential, or is there another side effect?
No, it's basically that blood related thing. And I really wish there was some way we could surgically go in and remove that blood related problem with respect to clozaril, because from an efficacy standpoint, it really has a lot to offer. Good questions. Yeah, this has been a pretty general look at antipsychotic drugs, and as you go from one antipsychotic drug to another, there are certainly similarities like we've talked about here, but there can be a little bit differences in terms of mechanism of action, and some practitioners are very tapped into those differences, and therefore have their favorites as far as utilization of these particular substances are concerned.
Would aripiprazole be one of the newer generation antipsychotics, or am I misremembering that?
No, you're remembering it correctly. And in fact, there's sort of a subfamily of agents there, of which there's, and I don't know how many now, but there's a number of agents that fit into that category. Yeah, pretty soon we're probably going to have to redivide these categories out again and sort of do older second generation agents and newer second generation agents, or even third or fourth generation agents. It depends on where you want to make that cutoff. It's been a huge category of development over the last decade or two, more than I would have predicted, actually. But I think some of it has to do with the fact that we're still looking for that magical antipsychotic drug. So attempts are made to produce those within the context of the currently available agents. But whether we're producing enough differentiation there or not to really be satisfactory remains to be seen.
And if nobody else has a question, I had another one. So psychosis is not a side effect, a symptom of schizophrenia, and schizophrenics can have both positive and negative symptoms, correct?
Yes, they can have both positive and negative, and really probably if somebody that really understood this stuff well was talking to you, they would tell you that schizophrenia is a subtype of psychosis.
Okay. So I was wondering, for people that with other disorders that cause psychosis, do the dopaminergic drugs help them more, since those help usually with the positive side effects?
I may be on a slope here. I would say yes, but I might have to review that to make sure I'm confident about that answer.
Okay. Thank you, Keith.
You're welcome. Thanks for asking.